I'm first going to do a little video clip, and then I've got the...
You don't want to put the video in a PowerPoint.
No,
And then you just click and then the video play.
so this is a separate one. It's a little video clip that I got via email now. And then the PowerPoint is that one.
So what I want to do is, so this PowerPoint, where's the PowerPoint that you're presenting now?
The first one? Yeah.
First one. So what I do is, I'll just create the slide, copy that slide, copy, and paste. Enable editing. Okay.
Doesn't allow you to. Otherwise, we'll just
Look like. Let me just see. Okay. Doesn't allow.
That's the video.
So when do you want to play this?
I'm going to start with it now.
So then we probably just need to drag it, drag the video to the home screen, and then I'll put it up, and then you can play it.
Right, everybody. I hope everybody had enough to eat, and I'm just going to wait for our chairman to start behaving. Guys, I hope that what we're going to do now is a first at this Congress, but also for you guys, you're going to probably see this for the first time. How do we manage an airway, especially pediatric airways? It was always a challenge for me, especially with dental work, especially if the dentist starts working on the lower jaws. And we are fortunate to have a colleague, Dr. Chris Kaywood, who I was privileged to call my partner, who developed these. 2009, we started with this, developing this little pillow, and then end of last year, the Kaywood chin lift. Now I want to show you a little clip of how practical this thing is, and then Dr. Kaywood can say a few words on it. So let's see if we can, is it going to play? Okay. Please come and help.
Just drag it to the extended window, doctor, because I won't be able to see the escape. Okay, let me just do it, start it over again.
We can't do the light. Okay.
It's a sound on the video.
Yeah. Het zit goed die ding in, Chris.
Wat?
Zit met die...
Ja. Oh, then put the mat back in first.
Okay. immediately the amplitude goes up. Chris, you want to come and say a few words about it?
Okay, it's pretty self-explanatory. Just Louis and I have been doing sedation. He prompted me to help him to make something to lift up the chin. It's because it's a big problem when the dentists work, especially in the kiddies, because children, as we saw before, to get them to cooperate in the dental chair, you have to get them into the slightly deeper sedation where they actually fall asleep and they can't maintain their own airways. Although they can still cough and laryngeal reflexes are there, but their airway can't be maintained. Then when the dentist works on the lower jaw, especially drilling on the lower teeth, tends to push the thing down and then you're having trouble. So this fitting over the shoulders, we put this little strap around the neck and then you just elevate the chin with this like that, and that keeps it nice and stable. The dentists also enjoy it because you can see he's got his hands on the thing there, stabilizes his hands while he's using the drawer and the instruments and so on like that, and it's just very effective in maintaining that airway. And so the moment you know if the breathing stops, you know water's got in, it's not the airway that has been compromised, and it really helps a lot.
All right, Prof. Sorry. Moment.
Equipment too, but I think the most important thing is to get the measurement right before you start the
Yeah.
sedation, because once you sedate the child and then trying to fidget and get correct, you can have a problem. So
All right.
get the correct position first, so it
Okay.
can be adjusted.
It is adjustable, and I have used it on a few adults as well, if I can get it around the neck. Unfortunately, it doesn't want to go around my 170 kilogram patient. But guys, this is what I think is groundbreaking work, and I'm sure there's more engineers in this audience than just Chris. What can we do? How can we make life easier for us and more safe for our patients? And because of this, I'm doing stuff that nobody else wants to do, especially with kids. So I don't recommend doing it if you don't have the experience, but please, it's out there. The expertise are there. Come and learn with us.
Another point is I think it's important, I usually roll up a little towel under the shoulder because it's like friction and it sits better, otherwise it tends to slide off everything.
I've got my K-Wood pillow. I'm sorted. Thank you. All right. So, guys, yeah, please inquire about these things. Hopefully, I will show you another video clip that we've made about this thing tomorrow morning. And this patient was actually awake while we did it, and he was completely compliant. So, yeah. Our next session is Prof. Roelofse. I don't think I need to introduce him, except that I want to say, please, guys, if you haven't touched this man's hand, please make the effort to do so. Get into his brains and tap as much as you can. Come alongside him and steal as much as you can of how he does things. Literally, we've spoke about it during lunchtime now. Who wrote the book on sedations or on procedural sedation? So, Prof, without further ado, I don't think we need to introduce you anymore.
Would you remove this one to how do you move to the
Maybe
right?
for you guys who don't know, Prof is
Niks
also
aan
one
hou,
of the
Prof.
co-authors of the guidelines for adult and
Daar klik
pediatric
Prof vorentoe.
sedations. This is a little booklet that Salsa gave out.
Some
If you
is
haven't
working.
got it, you can get it in an electronic form and it's for free. There's a lot of info in here. Go and study it and it helps a hell of a lot. And I'm sure it will help you to stay out of trouble. So please follow the guidelines. There's the man himself. You can talk to him in person.
You just said
I
it
think
now.
it's 3,500 rand for the pillow and the
There it is. Top. Go further. Now to go down. That's 6. Number 6 is there.
Unfortunately,
Yeah.
this stuff needs to be molded. It costs a lot of money, and because we can't make it in bulk,
Which way do I
it's
go?
very
That
expensive.
one? Okay.
So,
Probably might nader en proximaal.
Baie dankie hoor. Okay.
yeah, it is. Speak to
Louis, thank you very much about that brain tapping. I mean, I just had a WhatsApp from my wife. She said, "Are you not sleepy?" I said, "Well, you know, we have the sort of way in that we, for half an hour, if I have time to do it, go and for a little nap. And this is the time now, you know, for that nap. So that's why I got it. I said, oh, I'm still awake. Well, I must just find out how does this work. Okay. I'm going to talk about depression. And some of you may say, I've done hundreds of those. What are you going to talk to me about? Well, the use of antidepressants. I have news for you. Graham said something interesting this morning, and you'll find it out when I come near the end of that lecture. And he said, what do you need for this procedure? And this is what we should ask ourselves every time that we do a case. What do you need for a 22-year-old man on an antipsychotic drug and a serotonin reuptake inhibitor with a surgeon standing just behind you and waiting with, well, a dental case like this to inject? Okay, we'll come to that. That was just for a start. So, I want to make it very practical. You cannot make a lecture like this practical without saying something. I'm a little bit behind without saying something about a little bit of how many are there? Are they really a threat to us, the antidepressants? What I have there for you is to say to you that just remember, you cannot do any patient on antidepressants if you do not know how it works, for that matter. So know your drug. And I find like quite a number of them nowadays are generic drugs. If I ask the patient, then they give me a name and I stand for a moment and think, but I've never heard about that name. And then I work it out. It looks like very clever. But please do remember that you need to do the preoperative evaluation. I've asked myself so many times, the patients on antidepressants, and by the way, the World Health Organization said by this year, this will be the second biggest cause of morbidity. Well, very important. Is this always an ASA2? Are they not ASA3 patients? Especially when they've got comorbidities and when they are taking more than one antidepressant drug. Now, I'm not going to talk about that. I'm just going to show you that. Those are the neurotransmitters. I need to say something about GABA. You know, it's a benzodiazepines work there, so to speak. There is a drug by the name of Risperdal, which is clonazepam, works on the GABA receptor inhibitor, and then glutamate. Now, we can talk the whole afternoon about glutamate. Glutamate is a very interesting drug because it is believed that this drug can be used to treat depression. And I'm not going to say anything more about it because I'm in a political field maybe, so I'm just leaving it out. I just want to say to you that the only one of the drugs that are accredited by the FDA to give for depression is the nasal form of ketamine. All right. So what does ketamine do, that makes him such a good drug, is that it increases extracellular glutamate. And glutamate is then an excitatory neurotransmitter. So if you look at the psychotropic drugs, I'm not going to go through all of them, I'm just going to touch on that. And you know that the benzos, they are psychotropic drugs. Depends how much you give. You give too much, they sleep. If you give a little bit, then it becomes a anxiolytic drug. If you look at the antidepressants, and I'm not going to go through all of them, I'm just struggling to get going. Then you see there the tricyclic antidepressants. I'm just going to say a bit about that. I'm not going to say much about the rest, but the selective serotonin reuptake inhibitors. And you know what they do? They increase serotonin. Now, Reinhard was talking about in his lecture about using other drugs than the opiates, and there are some of those drugs that increase serotonin. For instance, tramadol. So it's a very good reason that we talked about it. There is a new story that fentanyl also increases the levels of serotonin. I'll come back to that a little bit later. Okay, look at the top, the selective serotonin and noradrenaline reuptake inhibitors. It is universally, all over the world, being believed that that is the best serotonin inhibitor. The least problems. Not going to take anything about, but saying to you, I want you to have a look, at the antimanics, lithium. Sometimes with some of the drugs, people add lithium. So I'm just going to say a little bit about lithium. And then trazodone. I don't know if you people use trazodone. Nobody can decide at this stage what is it. Is it a tricyclic antidepressant or is it really an antipsychotic drug? But if somebody asks me about something to sleep during the night, I say to them, try trazodone. 75 milligrams, it is what is called molipectin. Okay, these are the antipsychotic drugs. This patient of mine was on an antipsychotic. And I'm not going to give you all the names. It's not necessary to know that. Then just to remind you that the anti-epileptics are being used for pain. It is being used for depression also. Don't forget that. Pain and depression and anticonvulsant. Well, I want you to remember, if you forget anything that I said this afternoon, that a patient on Parkinson's disease drugs, they are already, if they drink some of those drugs, they are already at an advanced stage of the disease. Don't stop the drugs before sedation. And if you look at the top one, levodopa, madopar, increases serotonin levels. So we need to take consideration of that. I'm struggling a little bit to let this move. Now, something on the tricyclic antidepressants. Well, it's a popular drug. It's being used also for pain. And it's an important drug for sedation purposes. If you look at this, then you see it'll cause a dry mouth, urinary retention and constipation, blurred vision. Ketamine may make it worse, I'm not certain about that. And then it increases on intraocular pressure. Now I want to say to you, if you don't know it, that patients with narrow angle glaucoma, you know they can get an increase in intraocular pressure. Do you know that midazolam can cause an increase in intraocular pressure? All right, let's skip that because time is limited. I've already said to you that the antidepressants increase serotonin levels, and I do not call this the serotonin syndrome. When you get an overload of the selective serotonin inhibitors, you get what I call serotonin toxicity. I can skip that because I've already told you about that from the bottom. You see Madopar right at the bottom, increases serotonin. I'm not, yeah. Now what about the antipsychotic drugs? It's also called the other drugs. I like that, what people say, the other drugs. And it's used for schizophrenia, and this is the patient I'm going to tell you that I did. And I'm going to sort of present a sort of technique that I think works well. Drugs are often combined with other drugs. You see there lithium, but remember the drugs that those people drink can cause extrapyramidal effects. Start, you know, especially during the procedure also. I'm just going to skip that. You see there Risperdal. Risperdal is clonazepam. It's a benzodiazepine. And if you give it for more than 4 weeks, people say you get addicted to that. Clonazepam or Risperdal. Now, what about lithium? If a patient is on lithium, which is often so with the antipsychotic drugs, please see that you do the blood level the day before the operation. And there you see the blood level should be between 0.5 to 1.2. So what happens if it's the blood level is 1.5, 1.6? They become very sleepy during your sedation, and they can go even in convulsions. I've seen one that was sent to my son, who is a physician in Belleville, on convulsions, and we had to put her on a ventilator. We did nothing, we just treated symptoms because they recovered within 24 hours. Right, this brings us about the implications of drugs for patients on antidepressants. Well, I would like to say to you very little if you know how the drugs work and what the pharmacokinetics of the drugs are. It's very difficult to predict whether they potentiate the effect of the sedatives, which would be great. Do not stop them before sedation. I told you the biggest problem, again, is drug interactions with these drugs. Now, this is one of the problems we face. We get to a psychiatrist and prescribing those drugs. Look at the top, Rivotril. That is clonazepam. The next one, Remeron. Nobody knows whether it's a tricyclic antidepressant or an other drug. Luvox is selective serotonin inhibitor. Lagactin is an antipsychotic drug. And Nefrenil is a tricyclic antidepressant. And they wanted me to do the sedation for that case. Well, I met my friend, which name is Timothy. There's Timothy. And you can already see there that he's not the ideal case. Look at his neck there. And when he came in, he looked at me and he said, "Professor, I want to say to you something. If you don't tie my hands to this dental chair, I'm going to murder you." Now, I wonder how many of you would go on with a case like that. But the point is that I was struck by what am I going to give this patient that will work well. All right? I'm not going to go all of that. I'm just going to say to you that I used propofol, I used midazolam, and I used a little bit of fentanyl. Now you will wonder why I do that when I come to some of the slides, and I'm nearly there. Sorry. Okay, what can the antipsychotic drugs cause that would trouble us? Well, it's called akathisia. I'm not going to go into that. I'm just going to say to you, it leads to restlessness and a compelling need to move. That means like extrapyramidal symptoms. And the next slide, I'm going to show you dyskinesia, patient on an antipsychotic drug. So if you got a patient there in the dental chair or wherever, have a look at that and look at the nuts. Okay, that's dyskinesia being caused by antipsychotic drugs. So it gives itself away. So I'm to the point where I want to say, what do you need to do for this procedure? What can you give that will make this comfortable for everybody? Maybe a new approach. I'm going to tell you what I'm doing differently. The second thing, maybe thinking a bit more on how to approach the patient on different antidepressants. Especially my techniques. Which drugs are really safe? Are they safe drugs? That's a very interesting question if they are on more than one of the antidepressants. And then moderate versus deep sedation. Simon talked about that, this moderate versus deep sedation. Okay, so this is the case report. A 22-year-old male with schizophrenia for removal of wisdom teeth. And you know that can be quite threatening if they are difficult ones. He's on a drug called quetiapine, or Seroquel. I remember many years ago, there was an 18-year-old child that came for a dental procedure, and I gave him ketamine. You know what happened? He became hallucinated, all right? Quetiapine, you see, that's an antipsychotic challenging us. And this is a drug, quetiapine or Seroquel, that we use for schizophrenia, you see, for bipolar disorder and major depressive disorder. And it's a drug that can cause extrapyramidal symptoms. Now, then the patient is on Lexamil. How many of you know Lexamil? See patients who use Lexamil. So we're using two potent drugs. Now, why do I say they are potent drugs? Because if you look at the slides coming saying, are they safe, these antidepressant drugs? This is literature. This has been proved that some of the antidepressants can cause cardiac arrhythmias and patients may even die. And this has happened before. All right, this is the antidepressant use. And can you see at the bottom there? Now I've got to give to a patient sedation, and Lexamil was one of the drugs that they found may cause cardiac arrhythmias. Now, if you look at this, this is quite interesting. You see the drug by the name of fentanyl there. There are questions about fentanyl being used, and I use it quite often, but I'll tell you now how I do it. Now, there is also a question about those drugs that belong all to the phenylpiperidine group of the opiates. So if you use these drugs, you've got to be extremely careful when you do patients on antidepressants, especially antipsychotics. I have got an answer to that. I will probably use it by giving small doses. Okay, so our approach as usual, I'm not going to go through that. What worried me, and I think this is one of the things that we talked about this morning, is how do you approach the patient? I phoned the patient, and the mother said to me, I cannot speak to the child, or that he's 22 years old. And I thought, well, this is some big problem for me. So I didn't speak to him. Now, what are the sedation implications of antipsychotic drugs? Any effect on vasopressors? We're not reasonably certain about that. The antihistamines, we've got to be careful because of extrapyramidal symptoms. The antiemetics, Maxilon, can cause that. Ketamine, you see I've got there a query. And then the analgesics, I've just sort of went through them and showed you. I'm not going to go through that. Those are the things that can cause extrapyramidal symptoms when using the antidepressant drugs. Now, so which drug did I use? Now, I want to give you this with the back of your mind. What do you need for this procedure? What about the level of consciousness? Which level should you go for a patient like this? Moderate or deep sedation. So this is in preparation. And I wrote there, if you target immobilization, which you probably have to do in a case like this, you will target deep sedation. I want to say it again. If you target immobilization, you target deep sedation. And then I said to me, okay, what are the biggest problems that I face in line with what Graham said this morning? What do you need for this procedure? You don't need the dentist standing right behind you. You say to yourself, what do I need? And you will see there what I wrote down there. I need something for pain. I need something for anxiety. I need something for awareness. There's a story about knocking you out. The drugs that I'm going to use, and pressure. You know that if you press here on the mouth, patients may sometimes complain, even if they have no pain, because what we give does not take away the pressure. And I said to myself, okay, I've got a local anesthetic that I can give, so we can make the anesthetic, so to say, speak. This is a thing that I've worked out with the maxillofacial surgeon. Say, I want you to inject just the one side. We start on the one side, and when we're satisfied that it is working, what we're giving, then we go to the other side. And I'm telling you, this works well. Okay, which drug can I use then for this pain, awareness, and anxiety that I'm talking about? I am not a big fan of midazolam. I like propofol 20 milligram doses. So for this patient, when I put in a cannula, I give him 20 milligrams of propofol. And propofol is so short-acting that you can repeat it in 3-4 minutes again. And I start with a TCI Alaris of propofol 20 micrograms per ml. It sounds a lot, but for these patients, we need quite a lot. Okay, how do I target pain? I give them perfalgan. Remember, this is about 20 minutes before the procedure. And I like magnesium sulfate. I'm glad you talked about it. Magnesium sulfate, I think I do quite a lot of bronchoscopies. If I do get a bronchospasm, first drug I give them is magnesium sulfate. It works like a charm. So I started with perfalgan, started with magnesium sulfate, and then I gave fentanyl. So what I'm saying to you, I said just a little while ago, fentanyl can cause serotonin syndrome. I'm giving small doses. You see there at the bottom, debatable whether fentanyl and propofol is not a better choice. You know, it works within 90 seconds. After 10 minutes, there is still 40% of the drug in circulation. All right, what about ketamine? You know the drug, you know it's an NMD receptor antagonist, like magnesium sulfate for that matter. And you target your dosing according to the time of the drug to take effect. And remember, if you push it in, you may get apnea. So it's about 90 seconds before you get an excellent effect of ketamine. Okay, so I agreed with the surgeon how I'm going to do it, so I want to tell you about this. And this, if you haven't used it before, works very well for deep levels of sedation. And you will see there what I mixed. I took 100 milligrams of ketamine, and I added 100 milligrams of propofol. So I made a 1-in-1 ratio solution. And I give my drug according to the dose of ketamine. So this is now a combination 1-in-1 ketamine and propofol in the syringe. So I work out how much will I give ketamine. So I give them 0.3 milligram per kilogram, That's about 20 milligram. And if I give 20 milligram, that is 20 milligram of propofol, you see? All right. So that lasts about 15 to 20 minutes. And I give the surgeon 2 minutes before I say, okay, now it's time that you can come and go further. We did not have any complications with this. Did the procedure with no complications, not moving, recovery quick, did not know anything about the procedure. Now, where do I get this 0.3 milligram per kilogram? The first man that started using ketamine, and this is not for anesthesia, for procedural sedation, quite a long time ago said if you give ketamine, you want to give a safe dose for sedation, that's 0.25 milligram per kilogram. And that's where I come from in giving 0.3 milligram per kilogram. Now, I'm nearly there because I haven't got a long time. We can talk a lot about these things. I just want to show you that. Magnesium sulfate. This is why I use it. Have a look at that. Magnesium reduced post-operative agitation. So we're working with patients that may be getting agitation because of the drugs that we use. Magnesium also reduced pain. I think Reinhard mentioned it this morning. And I mean, I don't like that one because I don't use pethidine, but it reduces pethidine consumption. So if you work it out that pethidine is part of the phenylpiperidine group of opiates, like fentanyl, alfentanyl, then one can probably say it reduces consumption of these opiates. Okay, I'm nearly there. Other different techniques that will work also. I suggest that you think about it, what I said. What do you need for this procedure? Don't worry about the surgeon. What do you need for this specific patient? I'm saying again, I targeted analgesia, anxiety. I've shown you everything about this. Let me conclude. Give us information what your approach is to difficult groups of patients. And I love this photo, Nadia from Bloemfontein. Thank you. Dankie. Kia Leboa Hamburgers. That's another one, isn't it? What's the other one? Okay. Okay. Thank you very much. Anybody wants... Who's going to tell me what else are they going to use? Do you agree with that sort of approach? What do you need for sedation? All right. Thank you so much.
The expert has spoken. There's no questions. Let's proceed, and we can get home. Prof, you can do the rest of the conference, and we can be at home tomorrow morning early. Just by raising the hands, how many anaesthetists in the audience? All right. You're outnumbered here. How many full-time sedation practitioners? Okay. Right. Now we know who the speakers are for the next Congress. Thank you, Prof. Our next speaker is Dr. Peter Canellis. And Peter is in private practice in Joburg. Now I need to just get my stuff. He's an undergraduate from University of Pretoria, did the diploma in sedation and anesthetics, and he qualified as a doctor in 2001. Completed the diploma in anesthetics in 2004 and was one of Prof. James Roelof's first trainees. No, he wasn't the first trainees. He qualified in 2013 and currently provides general anesthesia and mobile sedation for a wide spectrum of medical procedures. He's also the current secretary of SOSPOSA, so welcome Dr. Peter Canellis. Right, I need the technical guys to come and help quickly. Yeah, it's, I hope. Yeah, it's your slideshow. Okay. It's your, okay. Yeah. Just pull out one, sorry.
Pull it out and plug it back in. So this one. Yeah. Cancel. Yeah.
Hello. Thank you, Louis, for those kind words. Afternoon, everybody. My name is Peter, and it's lekker to be here in Stellenbosch. It's lekker to see so many familiar faces. But what's more inspiring for me is seeing all these new faces. And with these new faces comes a plethora of knowledge, and I'm hoping to tap in on that. So please, guys, keep this interactive, and let's chat about this. Today we're speaking on capnography and prevention of sedation disasters itself. I must be quite honest, it's daunting speaking on the back of a sedation giant like Prof. But the more you think about it, the more you realize it's these giants that uplift us on their shoulders and make our sedation journey a comfortable one. So thank you very much for Prof for everything that you've done for all of us here today. And I think the audience and myself have something in common today. I don't know what the audience is going to say, and quite honestly, I'm not pretty sure I know what I'm saying. So keep it interactive, guys. So the next slide that I'm going to show you guys is something that you don't want to see when you're flying back to wherever you're going. But what it reminds me of, not about COVID times now, is what scares us. And I'd like you guys, with a show of hands, put up your hand and give me a phrase or something that makes you fear your sedations that you do. So put up your hands, I'll call you out, and just tell me in a word or two what scares you when you do procedural sedation. No volunteers. High BMI. Dik nek, airway problem. I like what you're saying. Prone position, airway problem. Anyone else? Stopping the airway. So you see, guys, there's definitely I think a common thread here, and that is airway. And oxygenation and ventilation, I think, is the backbone of safe sedation. And with that, I bring on this following slide, which is quite a powerful slide. And I think it's where we're starting, but it's as well as where we might end our sedation talk on capnography today. And this was a global anthology of records derived from above 160,000 procedural cases done and recorded adverse events. This was done by Kiera Mason and documented in 2019 in her journals. In summary, it's between 2010 and 2018, there was an estimated 165,000 sedations, and they recorded the adverse events. The mean age was about 33 years of age, and it spanned over 39 countries and 6 continents. And basically, in summary, the most prevalent adverse events were as follows. 7.8 per 10,000 was oxygen desaturation. Just over 5 per 10,000 was airway obstruction, and just under 5 per 10,000 was apnea. So you can see the airway is involved in everything here. The significant predictors of adverse events were ASA3 patients, sedating outside the operating room, and the other one was sedating after hours, so in other words, after 6 in the evening or so. Which brings us to what is capnography. So I'm not an academic, and I've opted to leave all the technicalities about capnography out, but give you guys the basics, because I think the basics is what sticks. And we've heard a lot of the stuff today, but we'll go through it again. So I've put a background picture of an island where my parents are from in Greece. I'm fortunate enough to have a home on the bay there, which I'm looking forward to seeing in August, barring monkey and COVID and the Ukrainian war. But as I said, I'm biased. So capnography comes from the Greek word kapnos, which means smoke. It's from metabolism, a natural waste product of cellular energy production. And CO2 is a compound molecule made up of 2 elements of oxygen, 1 element of carbon, and it's colorless and heavier than air. The physiology of carbon dioxide is it's a byproduct of energy production. It's produced by all living cells. It's diffused through the bloodstream to the lungs, and CO2 is then eliminated through alveolar ventilation. Here's a video clip of my own capnography machine that I use daily. You can see it's a recent one there. And I just wanted to show you the values that I've set on mine, basically. So capnography is basically a waveform giving us end-tidal CO2 in a graphic form. Our capnometer is a digital parameter over there. We've got our respiratory rate, oxygen saturations, pulse rate, and your integrated pulmonary index, which is what I think Simon alluded to earlier. It's a parameter taking your end-tidal CO2, your oxygen saturation, and your respiratory rate and pulse rate, and working it through an algorithm and giving you a value out of 10. 10 means you're good to go. 1 to 2 means you need to relatively have airway intervention over there. So the basics on oxygenation versus ventilation. Oxygenation is the process of getting oxygen into the body, whereas ventilation is the process of eliminating CO2 from the body itself. The differences between capnography versus pulse oximetry. Capnography measures end-tidal CO2, whereas pulse oximetry measures your oxygen concentration. Capnography reflects ventilation, whereas your oximetry reflects oxygenation in the level of your blood. With capnography, it's possible that early indication of apnea and hypoventilation can be alluded to, whereas with pulse oximetry, it lags, the values lag with apnea and hypoventilation. Capnography, respiratory depression is 28 times more likely to be detected with capnography than pulse oximetry alone. And researchers have found significant lag time, as I said, up to 4 minutes between end-tidal CO2 values, abnormalities, and oxygen saturations. Some basic waveforms of capnographies. We've got our normal waveform over there. We've got our start of exhalation phase, our plateau phase, and our inspiration phase there. Our normal oxygen concentrations is 95 to 100 with end-tidal CO2 of 35 to 45, and the baseline is always 0 there. That is a normal end-tidal CO2 waveform. Apneic waveform looks something similar to that. It's a normal, your oxygen saturations are normal or low depending on the duration of apnea. Your end-tidal CO2 returns to 0 there, or you get a 0 reading there with apnea. And your respiratory rate is 0 as well. Some causes of apnea is cardiac arrest, respiratory depression due to opioids and sedatives, displaced ET tube, obstructive sleep apnea, apneic capnographic waveform. Bronchospasm, a waveform looks like that. One of our delegates said the first thing is cough. Well, here you have it in the waveform itself. Your SpO2 might be normal or low. Your end-tidal CO2 can be normal, low, or high, depending on the nature of duration and severity, and your respiratory rate is either normal, low, or high. You basically have a loss of this angle here, and you get the shark fin appearance over here, and that is indicative, basically, of a bronchospastic waveform for capnography. Bronchospasm, COPD, asthma, obstruction in one of the limbs, presence of a foreign body, those are basic causes of a bronchospastic capnogram. Rebreathing, basically not for your end-tidal CO2, for your side stream, but this is how rebreathing capnographic waveform looks like. The baseline never returns to zero. Hyperventilation, your waveform is increased in amplitude and width. Your end-tidal CO2 is high and your respiratory rate is low. Your SpO2 might be normal or low. Causes of a hyperventilation waveform: COPD, chest wall deformities, neuromuscular disease, severe obesity, and use of central nervous depressant drugs. Hyperventilation is the exact opposite of the previous slide. Your waveform is decreased in amplitude and width, with a respiratory rate that is high, your end-tidal CO2, which is low, and your oxygen concentration can be normal there as well. There are some of the causes: MI, severe pain, severe infections, anxiety or panic disorders. Cardiac arrest or return to spontaneous circulation. Hopefully in our sedation practice we'll never come across one of these, but there it is. So this next slide is what my bedstand looks like, and these are the books I've been reading recently and currently reading. So, Reinhard, you were talking about a book that you're reading. Anyone else reading any books that have got suggestions for me to read? Show your hands, guys. What book? Yes, I'm listening. Little Lives. Okay. Anyone else with good books to read, suggestions? Spud again. Good. Well done. Is that referring to me? Okay, but I'm quite disturbed that none of you have mentioned the following book. And the same slide has come up many times. And it's a good book to read. And we do have some of the authors of this book here. And these are the new guidelines. You guys have seen this slide before. Louise has said, please read this. It is a good night read. It's an easy read. And every time you read it, it's quite common. You learn something new. So what does our guideline say regarding capnography? And I'm going to read this verbatim. It says basically, capnography, the so-called gold standard for the monitoring of ventilation, monitors the end-tidal concentration of carbon dioxide, which is believed to be a more sensitive monitor to alveolar hyperventilation than pulse oximetry. Healthy patients, ASA 1 and 2 patients, do not require CO2 monitoring. And since only ASA 1 and 2 patients qualify for sedation outside the operating theatre, the use of capnography outside the operating theatre is still controversial, they say. Therefore, capnography is not mandatory for moderate sedation, but highly recommended in fragile ASA2 patients. And these are also patients that are obese, COPD, obstructive sleep apnea, and some respiratory problems. They also say in our guidelines for prolonged sedation, example, some plastics, dental procedures, it's highly recommended that capnography be used for deep sedation and analgesia, as there might be a higher incidence of respiratory depression. Furthering to what our guidelines say is the following. Intention to treat analysis of studies showed hypoxemia incidence, which was not significantly lower in the additional capnography arm compared with standard monitoring. Additional capnographic monitoring of ventilatory activity resulted in improved detection of apnea. The last thing as well is quite important. Capnography techniques using nasal cannula, side stream, and transcutaneous methods are well tolerated by patients, but must never replace clinical monitoring of ventilation and oxygenation. So here's a practical approach of which, a practical example of which I've been using capnography. This is a young girl, Connie's her name, nephroblastoma. She's been operated. And Graham alluded to radiation therapy. So these patients are going for 15 or odd sessions on the daily with breaks in between for sedations. It's quite daunting doing these patients because you're not hands-on to them. You have to monitor them from a room which is 10, 15 meters away. Yes, I just wanted to show you, click and show you guys the clip itself. So there we are. Is it playing? Let's try again. Okay. So there we are. She's already being sedated. We haven't started with a radiation yet. I've got my capnography hooked up onto her. We're monitoring her through a camera on top there, and we're about to leave the room itself. And you're going to leave this patient ace alone in this room itself. And then you go and monitor her. I hope this one's going to work from a room outside. Okay, it's not showing, but anyway, you can clearly see there your capnography working there with your waveform, etc. Okay. Kan ons gaan na die volgende een? Jy moet maar wys. Ek is dom met hierdie goed.
Die muis terugkry tot op hierdie skerm en dan klik ons maar weer en dan kan ons nou weer daarvan af. Hierdie PowerPoint.
Okay, dis middag. Technology is a wonderful thing when it works. And when it doesn't work, we find ourselves all lost, it seems, eh? Anyway, so I've just got one more slide, basically, and if I can read it or go to it, it's basically, in conclusion, oh, there we go. Maar hy wys nie lekker nie, so hoor. Okay, in conclusion, respiratory status monitoring is essential and to enable corrective measures before hypoxia occurs. Be mindful of the following concept, guys. Pulse oximetry is a monitor of oxygenation. Supplemental oxygen can mask apnea and hyperventilation. And evidence suggests that a deep level of sedation in procedural sedation is associated with undetected apnea, which can result in desaturations. And I think it's a matter of time that capnography will become a standard of care in procedural sedation itself. So that's the gist of my talks, and I'd like to ask the audience another question. With a show of hands, who uses capnography on the daily? Vikas, what kind of procedures do you do? And this is, I assumed, outside the operating room, eh? Yes. Yes.
Because the time from when they switch off from the time that they switch off the radiation, if there's a problem, till you can get to the patient, might be a minute or more. And if you already are 3 or 4 minutes behind because you only picked it up with the pulse oximeter, you are going to be in deep trouble. Whereas with the capnography you are on time, so there's no problem.
Perfect.
But dental cases, anything. Whatever I do, I use the capnography because I think it simply makes my life easier and makes the patient safer.
Prof has a question.
I just want to say something about capnography. We all know this is a wonderful aid to make your patients safe. But I want to tell you what happened. SASSA contacted me and said they want capnography to be made mandatory. And I sent them a long letter saying there is only one country in the world where it is mandatory, and this is with Charles Cote pediatric sedation in America. The second thing that I wrote is, can you help me to get somebody that will police the people who do not have capnographies? And 3, there are people doing sedation that do not even know how a capnograph works. The 4th problem is that we are a developing country. And I mean, if you go to Pofadder, you won't see a capnograph, but you will see them doing sedation. So the value is not a dispute. I think the practical issues is a dispute. So what you see there in terms of highly recommended, it's an agreement between me and SASSA on how shall we approach this story about capnography. There's no negativity from our side. We believe it's a wonderful addition. And it's great for me to hear you people doing it on a daily basis. So thank you very much, Peter.
Yes, Prof. That actually was going to bring me to the next question. Asking people what they're using it for, what cases that they're using it for. The next question I have is, nothing is without its limitations. And as you said, we are living in South Africa, and these things are pricey. And your consumables are pricey. The machine is pricey. You can't always pass on those costs to the patients. And there's often, when you're doing side stream monitoring, where the tubes block and you don't see what's going on with this, you don't get a tracing. So there is limitations, but there's no dispute about its advantages. Any other questions? Yes.
I'm going to be devil's advocate.
Yes.
I'm against the capnograph because of the cost. I think we need to make sedations easier for the guys. There's already so few of us that people shy away from it because of the cost, how to get going, and then they hear the children dental sedation, she's just looking for trouble. I was 2003 with Prof, worked with Stewart Gibson and PE, and we had many blue patients. And our biggest problem was working with pulse oximeter without even a beep. And we sat back and we were used to anesthetics and we watched the pulse oximeter, and as you know, there's a delay. And many guys started sedations and then they stopped because of children. And since I've been sitting next to my patient with my hand on the patient's stomach, just monitor the breathing with my hand, my life has changed with pediatric sedations as such. I mean, you pick up one breath, you get used to that rhythm, and the moment that changes, it could be pressure on the tongue with the dental assistant with a mirror, it could be just working on the bottom tooth. If you sit with your hand on that patient's stomach, you will pick it up quicker than a capnograph. And you know what's happening with your patient, and then you can restore what's happening. I think the dilemma might be with MRI scan, where you might be far away, but even that, you can see the patient's movement on the blankets, and I think that will keep your clinical monitor sharp. And I still think that is, like Prof also said, never put clinical monitor beneath any machine.
I couldn't agree with you more. So when I sedate kids as well, I've got all my monitors, and then I've got my other monitor, which is my own hand, which I use to lift the chin up and rest on the child's chest, and I do feel the rhythm of the breathing, even though I've got my capnography running in the background. And it is stated in our guidelines, clinical monitoring of patients should never exclude, should never take precedence. Physical monitoring with equipment should never take precedence over clinical monitoring. So it is stated, yeah. Yes, Ilse.
If you've got capnography, when you go to court, they will ask you, did you have a capnograph? Won't ask you, did you have your hand there? They will ask you, and where's your capnograph reading? So you can't get away with that. And something that I do experience is the moment that the assistant, especially in dental work, when you teach her how a capnograph should look, they are very inquisitive, they like to learn, and you tell them about the graph. I've seen it so often. The moment they see a flat curve on the capnograph, they will automatically reposition the chin. And it's just, they feel like they are in control, they feel more comfortable and capable. So I can't see how you can do sedation without a capnograph. And then I've got something else here, is I actually brought it here. It is the line, I don't know how many people use it. It measures the CO2 on the one side and it gives oxygen on the other one. So I use it on every patient, and if you need oxygen, then you don't need to fiddle around, you just connect the tube and it works like beautiful.
Do you give supplemental oxygen on all your patients?
What happens with me, I've got a little oxygen generator. Okay. And it's just nice to see the saturation always at 100%, you know, and I think I give them like just a little bit benefit by keeping it at 100, though I've got a capnograph on as well. I just like to do it. It doesn't cost me anything because it works with power, and it can give, it depends on the flow rate. I usually run at a flow rate of about 3 liters per minute, which gives you 65% supplemental oxygen. As I say, depending on the flow rate, it depends how much oxygen it gives, but I just enjoy using it. And what I find is that the guys I work with, they also like it if the saturation is 100. They get a little bit, you know, fiddly if the saturation is under like 98 or 99.
Peter, I agree with you that capnography should become mandatory. And I think for myself, whether it's a GA or a sedation, the most important monitoring is still the capnogram. With an MRI, you know, you don't have MRI compatible machines. I learned a trick. I have a very brightly colored little foam that I put on the patient's chest, because sometimes you're at a distance and you can't see the abdominal movements, and it works very well for me. Thank you.
It's a pity you couldn't see that one picture. You could clearly, the last video clip, you could clearly see the child's chest moving, and you do monitor that as well, but it's always just comforting having your, you know, secondary monitor, your capnogram. Thank you very much, guys.
Right. Guys, again, you first and foremost a clinician. And I have a passion on this thing. Be cautioned by following protocols and guidelines and neglecting a patient. Right. I don't care what a protocol says. If I have to intervene against the protocol, that's what we have to do, because you're treating a human being. And a textbook and a guideline don't read a clinical situation. That's just me. I will stand up in court and have to fight for myself. So, having said that, I want to introduce our next speaker, Dr. Reina de Wet. Apparently he's a handsome young man, bald with a big checkbook, so...
Sorry, Louis. Ooh. Ja. Ek wil vir jou, jy moet nou vlieg, man.
Ek sal nou vlieg.
Okay, that's it. Right, that's it. At one of the previous congresses in Johannesburg, Vickers got us a lawyer, the Ulundi Bertel, and she one day gave a talk on the legal umbrellas under which we work. And to me, it was amazing. When you start with the Constitution and then all the laws and bylaws that are basically applied to you when you get in court, as you've said. The bottom one was the guidelines of your professional society is considered to be part of the law under which you have to work in this country. So you can't say, I'm doing sedation, but I doing my own thing. If you get a problem, if you have a complication, you will be weighed against those guidelines as well. So just out of interest. Fasting's the guidelines in sedation, ladies and gentlemen. I've previously done this talk, but we thought it is such important of such importance that we have to repeat this. Pulmonary aspiration is a rare but potentially life-threatening complication of sedation and anesthesia, and fasting intervals identical to those recommended before elective anesthesia were specified in 1985 for sedation and still authoritatively recommended and widely practiced. Procedural sedation intentionally targets a state in which protective airway reflexes are retained, while general anesthesia denotes a state in which they are by definition absent. With sedation, the procedures are often brief. There's far less active airway manipulation, and potentially emetogenic inhalational anesthetic drugs are not routinely used. So there's one we'll start to think, but surely the guidelines for sedation should be different to that for general anesthesia. If we look at the incidence of aspiration risk, there are publications to back this. General anesthesia, on average, it is 1 in 7,000 for adults, and 1 in 4,800 for children. And then procedural sedation, 1 in almost 14,000 for children. So it is clear, according to the literature, that the incidence of aspiration with sedation is much less than for general anesthesia. And from 1985 to 2016, only 34 cases of non-endoscopic sedation non-endoscopic sedation associated aspirations were reported. So aspiration during or with sedation is actually very rare. So if it's so rare, we surely need a new set of guidelines developed and designed for procedural sedation. And then fortunately ICAPS came around now. I'm proud to say that Prof. Roelofse is one of the wise men from ICAPS. It is the International Committee for the Advancement of Procedural Sedation. And they are exactly what they say they are, the international, multinational, independent consensus committee of prominent sedation researchers whose expertise spans over a diverse range of specialities and diverse practice settings. So they are the most knowledgeable of the knowledgeable and the most experienced of the experienced. They went about their business by putting 6 questions to the group, and the possible answers were sought, and then after that they found proof in the literature for that. And their publication was in December 2019 in Anesthesiology. The question was, number 1, is there a difference in the incidence and the outcome of pulmonary aspiration events between patients who receive general anesthesia, those who undergo sedation, and are the associated risks different between the two? There are many studies available. The Beach study of almost 140,000 pediatric patients had the overall incidence of aspiration of 1 in 14,000. That was what I referred to earlier, with a mortality rate of 0. The Rex study was an endoscopist-directed administration of propofol worldwide, with a mortality of 4 out of 650,000 patients, all of them not attributable to aspiration. The second question was, what are the known risk factors for pulmonary aspiration with general anesthesia and with procedural sedation? And as far as risk factors are concerned, The primary one emerging was esophageal endoscopy in adults. It is still the sedation that we all perform without thinking about it, with the highest morbidity and the highest mortality in the world. Then with a moderate quality of evidence, the presence of comorbidities, and I'll get to that just now, propofol as a sedative choice. Children under 12, obstructive sleep apnea in children, esophageal endoscopy, bronchoscopy in children, emergency procedures in adults and children, and absence of fasting in children and adults, and upper respiratory infection in children. So sort of all the things we were expecting would contribute. As far as comorbidities are concerned, there are quite a number of them. And it's quite important because this actually forms the basis of that multicolored document that I put on your desk. And I just thought it would be easier for you to follow it when you read on there, but not now, we'll get there. So comorbidities are intubation, extubations, emergency surgery or procedure, esophageal endoscopy or surgery, esophageal motility disorders, and bowel obstruction. Achalasia is the most dangerous underlying condition that a patient can have that we accept for a gastroscopy. Achalasia is a patient who hasn't got normal esophageal motility. They normally have a spasm of their lower esophageal sphincter, and their whole breakfast lies in there. And they've been fasted for hours. So that is, if your surgeon or your endoscopist suspects that, he must tell you about it. There's no way that those patients should be sedated. They should get a gastroscopy under a GA with a rapid sequence induction. Then other comorbidities, obesity, we get to that, co-administered opioids, and then very specifically the use of propofol is considered to be one of the comorbidities of the aspiration of risk. Age, the sedation duration, I'm going to talk later on ERCPs. Physician speciality, they say they're ashamed that the intensive care physicians are the worst sedation practitioners in the world. Then fasting, pregnancy, everybody think that pregnancy composes a higher risk, but it doesn't. Patient position, prone position definitely, and then of course there are a number of absent risk factors as well. The third question was, what is the evidence that fasting before general anesthesia and sedation improves outcomes? And the bottom line, unfortunately, is very little. There's very little evidence. The presumption is that if the stomach's empty, aspiration cannot occur, which I think is pretty close to the truth. Large studies have not identified an association between aspiration and non-compliance to fasting guidelines in adults and in children. The ER patients are always considered to pose a higher aspiration risk because normally they do not fasted, but in the literature it doesn't seem to be a problem. We all think that stress is delaying gastric emptying. Now that might be true, but it is not important from an aspiration perspective. And pediatric imaging under procedural sedation after the patient had been given oral contrast to drink does not pose an increased aspiration risk. The fourth question was, does compliance with pre-anesthesia and pre-sedation fasting guidelines negatively impact patient comfort, patient health, the anesthesia or sedation experience or workflow? And the answer is yes, it does, because fasting had been associated with decreased sedation efficacy, especially in the pediatric population. These kids are miserable. They're hungry, they're thirsty, and they just go out their way to make it for you as difficult as possible. And that unfortunately leads to sedation failures. When talking about fasting, we always have to keep in mind the diabetic patient, that they don't go hypoglycemic while they're fasting. The fifth question was, what is the impact of published guidelines and clinical strategies for preoperative or pre-procedural care, including fasting, on the prevention of pulmonary aspiration? And the conclusion of the group was that although it's possible that pre-sedation restrictions on solid foods may be protective, current evidence suggests that there might be no impact from either fluid or liquid restrictions, and the greater contributing risk factor being the prior identification of individual risk factors that you stratify when you evaluate your patient's pre-sedation. And the last question was, are there barriers to the development of fasting recommendations for procedural sedation that differ from existing guidelines designed for general anesthesia? And it's a matter of old habits die hard. We all know that the 2-4-6 rule actually works quite well. And by far the majority of our patients not been fasted that needs general anesthesia and be intubated, that the 2-4-6 rule actually work well. And I would say it's worked for me for 30 years. I'm not going to change it now. But ICAP says they're proof that you actually can be a little less strict on that. So the ICAP's recommendation about this is you have to risk stratify your patient. You have to classify the procedure as an elective or an urgent or emergent procedure. And the question should also be asked, if there is any comorbidity, should the procedure be delayed? So as far as the situation assessment is concerned, as far as your patient goes, ASA status 1 and 2 or 3 and 4, the patient with severe systemic disease, obesity, and kidneys less than 1 year old, and the patient with hiatus hernia is, it's very important to note those comorbidities. As far as the procedure is concerned, again, the upper GIT endoscopy and bronchoscopy are still the highest risk procedures to do. Regarding your sedation, the type of sedation and the use of propofol poses a risk. Where will the surgery be done and the sedation be done, in the primary or the secondary setting, and is delay advisable on the basis of fasting? Now this is the diagram that you've got, and they've very kindly, they've divided this into 3 columns, and before I get to that, right at the bottom here is a lot of information pertaining to the columns. You will see that, for instance, it states that moderate obesity is a BMI between 35 and 39, and a child between the 85th and the 95th centile. There are a number of quite informative notes at the bottom there. As I said, the devil's in the detail there. If we look at the column to the left, the green column, this is the patients or the patients having no risk factors. Now that is by excluding the risk factors in the pink or the red and the yellow group. Those patients pose a negligible aspiration risk, and they can have clear liquids unrestricted. Babies can have breast milk unrestricted, and food, formula milk, and non-human milk, we require fasting of approximately 2 hours. And there is no basis on which you have to delay or postpone these procedures. When we get to the middle, to the orange group, the risk factors putting patients into the mild risk factor group is severe systemic disease, moderate obesity, that is between 35 and 39, kiddies under a year old, and patients with hiatus hernia. Which procedures add to the risk? And again, upper endoscopy, bronchoscopy, and then where propofol is your primary sedative. Those place the patients in the mild risk group. They can all have clear fluids, unrestricted, but breast milk for the baby is 2 hours, and food formula or non-human milk fasting approximately 4 hours. And again, there is no delay of the procedure based upon the fasting time. The column to the right is the patients in the moderate risk factor group. That is the patient with severe systemic disease, that's a constant threat to life. Severe obesity, that's a BMI above 40. Patient with obstructive sleep apnea. The patient with airway abnormalities, you'll see it at the bottom there, there's a list of them. Hyperemesis and patients with esophageal disorders, and of course patients with bowel obstruction. All of those put the patients into the moderate risk factors, and the procedure and sedation, if there is an anticipated need for assisted ventilation or other advanced airway management. Therefore, the high BMI patient and the patient with obstructive sleep apnea, that places them in the moderate risk group. So for them, the old 246 rule applies. And no delay based upon the fasting times. If anesthesia care is available, you can basically do what your common clinical knowledge allows you to do. If not, if there's no anesthesia care available, consider ketamine as the sole sedation agent for obvious reasons. To conclude, ladies and gentlemen, the 246 rule in sedation only applies to the moderate risk group of patients. The moderate risk group should ideally be sedated in an area where anesthesia care is available. Should anesthesia care cover not be available, ketamine would be your drug of choice as your sole sedation agent. And most important, you will only get to know those risk factors if you properly risk stratify your patients pre-sedation. Thank you very much. Any questions? Laat ek gou vir jou bring.
Rainer, just a question about the propofol as being a risk factor for aspiration. You know, we use it extensively for our scopes, and in 20 years we've never had an aspiration, so I do not know where that comes from.
That is most probably because, and I'll refer to that later, that is most probably because propofol can, in the wrong hands, easily lead to oversedation, to airway obstruction, and you have to know the drug. If you know the drug, then you're fine with it. It's like remifentanil. Remifentanil is a brilliant drug, but if you don't know it, it's a very dangerous drug. And I gather their mentioning of propofol comes from that, because we all know, we use it every day, and we never have a problem. But you can move through the different levels of sedation very quickly with propofol. I gather it's on the basis of that. Okay.
Reina, that's a very, very interesting question that he asked, because you're right. Propofol is an anti-emetic. Now, I was part of this whole study. It was a huge, huge study. What you see here is putting together all information on specific things. And what we found is that over the years, and I think I can't remember, it's near 2000, went back to that, and we found that the drug that is a problem is propofol. Now, we don't know how much people gave and all that, but you're right, it's an anti-emetic drug. But this is a research study, what we saw. You don't have to believe everything. because you know, if you see that bronchoscopy at the top, I told them that bronchoscopy must come in there because I'm doing that bronchoscopies. And the other thing, which is quite interesting, if you look at the people on this group, then about 80% of them are Americans, of which about 70% are ER people. They're not really doing these things
with
outside
propofol.
the
Yeah.
way that we do it.
Yeah.
So I think one has to look at that and say, okay, this is what they got from other studies, that propofol causes this.
Yeah.
So maybe it's just a message for us. Be
Yeah.
careful,
Yeah.
you know, in what you give. Thank you very much.
That's right. Most probably they gathered all the information, and this is the list of patients or the number of patients that they had problems with, and every single one of them had propofol. So then the question comes up, maybe it's the propofol, or maybe the handling and pushing the propofol, but propofol is involved. That is how I saw it.
Hi, Reinhard.
Yes?
When you mentioned question 3, I'm just wondering that question put to the panel, if that, I mean, should that carry much weight? Because you won't be able to gather evidence because you can't really do a proper double-blinded study to say, okay, we're going to have 100 patients eat normally and 100 that don't, and then do anesthesia for all of them and see who aspirates the most. I mean,
Yeah.
I'm just thinking that question 3, the fact that there's very little evidence means there's not a scientific way to gather that evidence, not one that we would want to do. It'll be unethical.
Yeah. James, what would your answer to that?
All I said is what I said before. This is a study on what we got out from the case. I mean,
Yeah.
putting in the incidence of fasting before general anesthesia. That's what you see from there. I think if you look at that, if you see a reasonable article in terms of time, 2016, I usually look at the time that those things were published. Look at the top, 1993, 1998, 2016, a prominent group of people. So what you see, you can sort of say, well, it doesn't sound like fitting into everything that we believe should be there. But this is what we got. And this is what the report is.
Yeah.
What is the evidence that fasting before GA plus improved outcomes? Well, I can tell you again what was for me very interesting is that the high incidence of death with endoscopic procedures. So we're doing these endoscopies. Be extremely careful. There is evidence for somebody that wants to take you to jail that it is. Thank you.
Now for Nadia.
Just 2 comments. From where I work, if you have ultrasound available, gastric ultrasound is quite useful, just to see whether there is content in the antrum of the stomach or not. And you won't necessarily know exactly what, but you can see whether it's particulate or whether it's clear fluids. And on that basis, you can decide whether it's safe to proceed or not, regardless of the fasting times. Now I forgot my second comment. Oh, with clear fluids, it's not just clear fluids, but actually the volume of clear fluids that they take up to an hour or 2 hours before as well. So if you do prescribe it, like especially in pediatrics, where you have to like prescribe for them to still have the clear fluids, it's 3 mils per kg. So just two comments.
Yeah. For me, the take-home message from this is, if you want to stick to the 246, then it's good. But there is a movement, and there's very solid scientific ground to start to move away from that, especially in the pediatric population. Thank you.
Right. I think it's, again, just proving the point that guidelines is there to make it safer for us, easier for us, and for our patients. Now, I would like to quote Prof. Roelofse. When I started the sedation course in 2002, Prof had this quote of guidelines is there to protect us. 70% will follow it. 20% will push the boundaries, and it's those 10% bastards that we want to take out. So, am I right, Prof? So, yeah, our next speaker is Dr. Christie. Simon Christie. We've met him before, so Simon, welcome back. And I'm looking forward to this talk of yours. All right. Just need to quickly open your...
There's nothing, don't worry.
Oh.
Okay.
Okay. Just stand close to this.
Yeah. Okay. So there's no talk because it's ketamine and it's supposed to generate some discussion amongst people because the topic of the talk is ketamine. It's a nice drug. What do we do if we don't have it, or what else would we do in its place, or what would we use in its place? And I think this morning already we've gone over some of the analgesic options and the other options available, but we need to just get a perspective from the audience about ketamine itself and some of the things. So I'll start off the discussion and I'll just say about ketamine itself and how I use it. Okay, so we know in South Africa that it comes as a racemic mixture, so it's the two enantiomers combined in a 50-50 mix. And other places in the world, they get the pure S enantiomer. So, and it also comes in different concentrations, and as I alluded to this morning, just be careful about what you draw up, and because it's easy to mix the 10 and the 50 ml, or the 50 and the 100 ml, and you might find yourself waiting around for a bit longer than you thought. I think for me, in terms of ketamine, it's one of the most useful drugs I have, but I've learned with time that I certainly try. I used to give a lot more, and now I give a lot less than I used to. And I think it's extremely helpful in very difficult situations, but I think that there's a couple of things that I was taught. I started anesthetics in 2006, and I was at Tembisa Hospital in Midrand, and we were told implicitly that this drug, is extremely helpful for crash inductions or trauma patients and things like that. And I think the thing to remember with ketamine is that people always say it preserves reflexes, airway, otherwise it bronchodilates. These are all good things, but that actually its inherent process is a negative inotrope. Actually, it's just that if you have the catecholamine stores, it will induce a catecholamine release that will, outweigh its negative inotropy. But actually, it's a negative inotrope, and you must be very careful of a patient in the trauma situation who's been entrapped in a car or who's been needed to be extricated after a long time, and the catecholamines levels are unstored, and then its negative inotropy is revealed. But I think that's beyond the scope of sedation outside of the operating room. We won't be into those type of patients. And then another thing is, we were always taught we've got to watch ketamine and raised ICP, so patients with raised intracranial pressure, so you might be having to sedate a child with a VP shunt or hydrocephalus or things like that, and that doesn't really apply, and raised intraocular pressure also doesn't apply. So there's those sort of myths that have gone by the way. So who uses ketamine regularly? That's good. And what's the going dosage for ketamine? What would you do? Do you mix it with other things? Do you use it by itself? Vickers, use it by itself? Do you combine it?
I seem to be the guy that always asks questions. Okay, I think you assess your patient and the procedure you're going to do.
Mm-hmm.
So if the ketamine is going to be the drug that you're going to choose to do, if the ketamine is going to be the drug that you're going to choose to do to help you with the pain,
yeah,
then the mixture I would use, in this case, I would use a propofol ketamine mixture. I would use a higher concentration of the ketamine. Now, Prof alluded to deep sedation 1-in-1 mixture. That is a very potent mixture. That is something that could knock your socks off. So I would be careful using 1-in-1, but I regularly use 1-in-10 for instance, my endoscopy work.
Ketamine,
And
1 milligram to
1
propofol
milligram
10.
to 10 milligrams of propofol,
Yeah.
and it works beautifully. But then if I do a aesthetic procedure where there's a lot more pain involved, I would go to 1-in-5 or maybe even 1-in-2, but I seldom use 1-in-1 simply because it is so potent.
Okay.
So I think you could use one of the opiates with propofol in a similar situation and have a lot more problem with breathing.
Yeah.
You could use the ketamine in that low dose, and then you don't have all the problems with so much secretions. And so a low dose ketamine propofol mixture seems to be, in my practice, one of the preferred mixtures that I use.
And if you're looking at it, doing a case for sedation, how long, what are you looking at? So what type of cases would you use that concentration? Are you looking at educated thumb, little boluses? Or are you looking at running an infusion?
Okay, so that's a whole new discussion. If you do short procedures, that's what I've just discussed.
Okay.
But if you do a 6-hour sedation, then ketamine accumulates, and you need to know that.
Okay.
So even if you do a TCI, you are going to eventually have ketamine and norketamine building up to a very high. So I would use a 1-in-2 mixture for the first half hour, 1-in-5 for the next half an hour, and I might even use pure propofol after that, or a 1-in-10 for maybe another hour, and after that it's gone. So I wouldn't carry on using high concentrations of ketamine.
Okay, good. I think that's really reasonable. I agree with you totally. I think that's the aspect that also concerns me, is that you can get over a certain period of time, you get a rise in its context-sensitive half-life, and you've just got to be aware of that and where you're going. But ketamine is one drug, and it works by blocking an NMDA receptor, but there's 2 other drugs that we might use in sedation. Who knows them? They work in the same way, so they're analogous to ketamine, which are the other 2 that are very analogous, and that's their mechanism of analgesia. Prof likes one of them. Magnesium sulfate, and the other one, nitrous oxide, those are the 3, okay? So I also like mag sulfate, like Prof said, because I think if I'm a little bit worried about some of the hallucinogenic effects that you might get with ketamine and things like that, if I really want to keep it nice and clean, but I want the NMDA receptor mechanism of analgesia, then I will supplement with ketamine as well, 20 to 30 milligrams per kg, or maybe even less than that. I always think you can give, Prof taught me right from the beginning, you can always give a little bit more, but you can't take it back. So just give a little bit, you can always add some. So I like that a lot. I used to use ketamine and propofol, ketofol a lot, and then Marie and Prof and everyone started speaking about Rapifen and propofol mixed together, and I tend to do quite a lot of cases that are long, and I really like the combination of those 2 things, and I cheat, and some people will strike me down because I'll mix 2 drugs in the same syringe, and I'll run a propofol Schneider effect site TCI with Rapifen and propofol in the same syringe. And my opinion is it's not technically correct. I think they mix together well, so the posology of the drugs mixes well. I don't think there's an interaction there. But it really, really works well, especially for long procedures. I find it very, very titratable. I use it on especially colonoscopies. We do some venous ablation and phlebectomy work, sometimes small debridements. But I find that one of the most useful mixes I've got. I like the ketamine, but I've gone a kind of away a little bit from using it for the longer cases, and I just supplement 5 milligrams at a time. The other thing I use ketamine a lot for is I used to do, like I said, some sedations for MRI at a couple of places where we didn't have an anesthetic machine at all, so there was never the option to do a GA. It was pediatric MRIs for brains, not for chest, because obviously without a GA we couldn't control ventilation. And what I used to do with those kiddies, I think I've told a lot of people before, is that the drip used to be established upstairs, away from the procedure time, I often couldn't get there sort of an hour and a half before. And then when we would be downstairs, I didn't like midazolam at all for them because some of them were really, really small, couple of 5 months, 6 months. And I used to use a tiny bit of ketamine, 0.25 milligrams per kg, as literally an instant pre-med while the child's in the mom's arms sit there. And then I used to connect my Propofol and just start my infusion of Propofol slowly. And that's how we did all of those sedations in the MRI unit. That was, like I said before, Precedex. And then after a couple of years, Precedex came around, and I've used nasal Precedex as well, which is absolutely fantastic. It takes about 40 minutes, but the child will literally, you can do a CT scan, you can do an MRI. It works exceptionally well, 4 mics per kg in a small volume. So I like that. And is anyone using nitrous oxide regularly still? No one? No one in the practice? Are you using it?
I use it to distract the patient so I can get the drug off.
Okay.
Because it doesn't really work.
Yeah.
That's the problem. The concentration on its own is really not sufficient.
Okay. And anyone have a lot of problems with ketamine? What else does anyone do any of the infusions for its psychiatric effects? Anyone do any of those ketamine infusions for the psychiatrists and things? Do you do them? Yeah, yeah.
On whether or not it works.
Yeah.
In my personal experience, based on the few numbers that I've done,
yeah.
The first time you see the patient for a KET infusion, you say hello and they look down at the floor. The second time they look at you and, the third time they're smiling, and the fourth one they say, do I need to come back?
Wow.
I'm actually quite impressed with it.
Okay. So tell us
bearing in mind, though, that it's done in conjunction with using antidepressants
yeah.
and the patient's in cognitive behavioral therapy.
Yeah.
You can't just use it as a sole adjuvant.
Yeah. I think, basically they're trying to get to a stage where we don't do any electroconvulsive therapy anymore. So it's really treatment resistant.
It certainly has a role to play. The problem is identifying those patients that respond to it.
Yeah.
And before it's easy to see afterwards. It's figuring out who needs ECT and who needs ketamine before you start. And
okay.
that's a big problem.
So, and what kind of dosages how do you know what the kind of dosages are used, or what do you do?
There's another anesthetist in Durban who's also doing it. We say we want that emotional sweet spot.
Yeah.
You've got to get them at the dose where they start crying and bursting into tears, as terrible as it sounds.
Yeah.
But you have the most maximal emotional response to your ketamine.
Okay.
And it can vary from 0.25 up to 0.75, even 1 milligram per kilogram, depending on the patient.
Do you give it over as a
small infusion run over 20 minutes?
Okay. Okay. And then what are they like after that?
Weepy.
Weepy? And then do they stay around for a bit? What are they?
We keep them probably an hour or two, and then they go home.
And then they go home?
Yeah.
Okay.
But, this is done I'm not a fan of ketamine clinics.
Yeah.
Okay? This is done in conjunction with the psychiatrists.
Yes. No, I'm not
and, there have been the isolated cases where patients with severe refractory depression who they go to some a ketamine clinic somewhere, and 2 days later they've committed suicide.
Yeah.
Okay. So, we do it. We're very cautious about it, and it's done under very tight control.
Yeah.
Often these are inpatients in a psychiatric unit.
Yeah. No, I got you. I'm just wondering about the dosages in terms of what people's different experiences are on that, because they're doing the same thing here in Cape Town. So I just wanted to know if they've got
Can I ask a question? Do you have any use of ketamine in addiction?
So, not specifically in terms of it. I don't have any specific experience in it. Definitely in terms of chronic pain, like 100%. But, as a means of avoiding opioids, definitely. Those patients that come, but not from my perspective in a patient we try and avoid opioids, so we use ketamine as a swapping out. But I don't have any as a treatment for opioid. I don't have any experience. Do you? Yeah.
just from the pain perspective side, there's a high incidence of addiction, the casual drugs. So we try and stay away from it because you can create another monster. So I would really recommend, if you do have a problem, those people need multidisciplinary approaches and not drugs. The addiction cause is not a drug problem. It's a mental or negative emotion problem.
You've done the chronic, you've done the pain
Yeah.
diploma.
So I do a lot of the pain infusions for CRPS, chronic regional pain syndromes, those type of things. Again, it's a dose-dependent thing, and it differs from patient to patient. So this is where the clinical skills and your experience come in. As far as the depression stories is concerned, I was taught you'd start with a low dose of 20 milligrams per hour and see how it does, and for a lot of patients that's enough. And then I've had patients which I've done up to 300 milligrams an hour, and they sit and laugh at you.
Yeah.
So, and those people need to be monitored, so it's different for every patient.
I just want to ask a question with the pain, the chronic regional pain that you mentioned now. A lot of those patients are addicted to opioids because of how they got there. So wouldn't that then also, the ketamine, be a bit...
That's why I say it's a multimodal thing, but CRPS specifically. So I don't want to make a discussion about it because we individualize every patient and treatment plan. But what I'm trying to say is ketamine is not the answer. Don't go from replacing one addiction with another one.
Yeah, I mean, you make a good point. I mean, it's definitely a drug of abuse as well and things like that. But so 100%, you know. So I mean, those are some of the. We've discussed a lot of the bad things about it, but what's also good about ketamine is extremely cheap, right? So it's extremely cheap, and I think from that perspective, and then I think the other good things about ketamine is that it's got a variety of ways in which you can give it to, which is unlike a lot of other drugs. I mean, if we look at Precedex, it has to be basically, you can give it as a short bolus, but ketamine can be IM, you know, so many various forms in which you can give it. That's quite useful in the sedation context, especially with kids as well.
Sorry, Simon, can I just fall in here for just another thing? My suggestion would be rather keep it simple and small doses than going with big boluses.
Yeah.
Like you said, if it's in, it's in. You can always titrate, give more over a period of time. But reassess your patient clinically. One of the things that I caught up with while we're doing this training sessions, people always want the cake recipe. There is no cake recipe for sedation. It's about your experience, and that's why you need to come for the training or do the diploma. And the other thing is, the more you do it, the only way you learn these things is by doing it yourself. And especially if we talk about the ideal sedation drug, which there isn't, the closest that you can get to safety is ketamine.
Yeah.
And I think Prof has been alluded to this for as long as I can remember. And it's coming out more and more. If you use it in small quantities, yes, there is no safer drug than that.
Yeah.
Right.
I think also just to bear in mind, it helps. I mean, ketofol, like we said, and we've described is good, but just bear in mind that in the wrong hands, any of these things is bad. I mean, I've got Janet Piercy describes a very strong point with her mom. Her mom dislocated her shoulder or something. She took her to a casualty, and the doctor said, "Oh, it's fine, don't worry, man. I'm going to give you some ketofol. It's really safe. You don't need any monitors, anything like that." Her mom basically went apneic, and the SATs went down to 70 for a while. They only realized that when Jenna told them to put the SATs on. So, you know, again, just because ketamine might balance propofol sedative effects there, doesn't mean that you can do these things without proper monitoring as we would. It's an advanced technique. All those things apply, you know. Prof?
Yes, Simon, I just want to put something straight.
Yeah.
And that is that there are many ratios.
Yeah.
1-on-1, you go and look at literature, there are people that research 15 different ratios. 1-on-1, 1-on-2, 1-on-3, 1-on-4, 1-on-6, and so it goes on. And everybody has got his way of doing it.
Yeah.
I agree with what Vika said. The 1 in 10 is the best ratio because people recover quickly.
Yeah.
1 and 2, well, it's a little bit more of ketamine, and patients recover quickly. Now, let's talk about the 1 and 1. The 1 and 1 is not the solution that I advocate for each case of sedation.
Yes.
But what is quite interesting, they did a big study and they called them the old elderly patients. I've never heard about that. Old elderly, that's above 85 years. And I'm not part of old elderly. Okay.
You've got about 40 years to go. 50.
And you know what they did? It was fascinating. They gave that old elderly patients a 1 and 1
Dose
ratio of ketamine propofol. And those patients recovered immediately. Within 5 to 15 minutes, they were sort of awake and fine. So it looks like we are getting to know more and more about ketamine.
Yeah.
Things that we really don't know.
Yeah.
Because he's quite right when he says we go for the lower dose, but the lower dose is also for certain other reasons. I sort of often use that 1 in 10 for an infusion for, say, 1.5 hours.
Yeah.
Because it's been shown that your recovery, if you use a 1 in 10 and you take out the ketamine at some time and just substitute it with propofol, your recovery is 24 minutes. This is what has been published.
Yeah.
So you've got to use it carefully. Don't think it's just fun. I was on one day phoned by 3 anesthetists who said to me, is it possible that ketamine can cause apnea? So yes, it's one of the problems.
Yeah.
Said, how did you get apnea with ketamine? This person said to me, I had it in my drip, and then it was near the end of the procedure, and I let that drip with ketamine run in quickly.
Yeah.
The patient got it.
You can conclude.
Oh, I think that's fine. Yeah, we can conclude. Okay, sorry, that was rather informal, but I think just set it up for tomorrow that we start to engage, because that's why we're all here, you know. Okay, thank you very much.
I again rest my case. If you follow the protocol and you weren't a clinical doctor, you're going to be guilty as charged. Right. Just as far as the slides are concerned, I'm going to try and get all the slides from all the speakers once we are done, and then we'll make it available for you. So if you do, I don't think there's any of the speakers that will have a problem with it. Then I want to ask a question. Has anybody perhaps got a ProPrac CS monitor, or an old one, ProPrac CS monitor? I'm really interested in buying it. Die groot ene, ProPrac CS monitor. My screen broke and I still like my capnograph, so I would just like to buy another one. Everything's got a price, Prof, but right now I'm... Okay, so our next speaker, I have the fortunate to introduce. Nou moet ek net gou eers my goed kry. Dr. Nino Haber. Yeah.
By the way, I'm a magician. I've just changed time to next month.
Right, Dr. Nino has been an anesthetist and sedationist for the last 40 years. Well, I'm not sure the sedation was that long, but yeah. He's been
We just didn't call it.
he's been around for a long, long time. And again, I would recommend if any of you guys need guidance, experience, this is the man to cling to. And because we're looking forward to your talk. Thank you.
So, this is the dead man's beat. I'll try to keep it a little bit informal. I think all of us have to, at some stage, go out, see a new practice. You have to confront the reality that you are now going to work in a place where you don't know the people, you don't know how it looks like, you've got no idea what to expect. And let me see if I can get this thing to work. So your first contact with this practice, whether it be a telephone call or an email or whatever, we're going to look at that. We're going to look at the appraisal of that practice, and I prefer to use the guidelines as a guidance in that. And then how do you prepare for this first case? So the first contact, direct telephone call from the surgical practice usually indicate a real interest in the sedation. You get all sorts of ways which you are contacted in. If it's a referral by the colleague, is he referring this patient to you because of your remarkable competence? Why doesn't he want to do it? Think about that. I'm not referring to locum work. But if you get a WhatsApp request, why does nobody want to do it? So this is my little recording for a telephone call.
Hi, is that Vikus?
Yes, can I help?
You must assist doctor at 8 o'clock on Thursday.
First call. Excuse me? Assist? I do sedations.
Yes, that conscious thing.
I do not recognize your number on my phone. Which practice are you phoning from?
Oh, the one in Benoni.
I mean, what is the name of your doctor?
Dr. Z.
What type of practice is it?
What do you mean?
Do you do dental work, for instance?
Yes, Dr. Z is a dentist.
Have you ever done sedation at your practice?
No, but Dr. Z says it will be very quick.
Okay, so I need to come and see Dr. Z, and then we can look if it's possible to do sedations at your practice.
Yes, but Dr. B said that you are so good you can do it, no problem.
Can I make an appointment to see Dr. Z?
Wait. Dr. Z says lunchtime today.
That's kind, thank you. Can I have your address, please?
You turn left at the McDonald's.
No. Just give me the address. I should be able to find that.
10 Luna Street, Heaven's Gate, Benoni.
Thanks. See you guys at 1300 hours.
Excuse me?
1 o'clock.
Oh, okay, bye.
No.
Hi, is that Viku?
I spoke to Alret this morning, and she says she had a call. She's never been to this practice before. The first patient is 2 years old, dental. They want to do a 3-hour procedure. It's a CP child, and nobody in the practice has any airway training, and they've never done a case like this before. So, and I think that's the sort of experience that we are exposed to on quite a regular basis. We are literally exposed in South Africa that a very small percentage of the people that do procedures that could possibly have been done by sedation literally knows nothing about sedation. So we are the educators, literally. And I'm going to relate another one. It is a colleague that actually does have a degree as a GP. And he works as a sedationist. No names, no packdrill, and no area. But what he does is, and this was revealed to me by a dentist, I said to him, why don't you guys do a lot of sedations? And he says, no, man, sedation is not the thing. It really doesn't work so lacquer. And I said, what's your experience? He says, no, man. the patients are always coughing and they go blue and it's really it's a mess. And I say, slow down. Tell me, how does this guy do the sedation? He says, yeah, he arrives there and he's got jeans on, but it's got these funny cracks in the jeans. And then he looks at the child and he tells the mum to turn the bum and he gives an injection from his pocket. I think it's ketamine or something. And then he goes outside to smoke and then the dentist has got to carry on with the child. So this is, and he then charges a fee for that. And then the child is still not awake when he's loaded into the car after the procedure and he goes home. This is what we are facing. This is the image of sedation in many areas in this country. And when I write these articles for the aesthetic magazines and stuff, that's what we have to face. We are literally the face of ethical, proper sedation in this country. You guys sitting here, I'm the guy that stands here and I'm proud of you. But we need to understand that we literally have to be the face of ethical sedation. Okay, so the category A practice is where there's been sedations done before. So the questions that you will have to go through in your mind, and this comes from the guidelines: does the practice provide basic intravenous sedation? Midazolam only? Do they provide inhalation sedation? Does the practice provide advanced intravenous sedation techniques with combination of drugs? Do children under 12 receive intravenous sedation at the practice? Which drugs are used for them? Sedation patients only ASA 1 and 2? Or do you do any fragile ASA 2 patients? Is the practice in good standing with the HPCSA? Now, I've read these guidelines a couple of times. That one I've missed. I have actually never asked the dentist if he's in good standing. I don't know if any one of you have done. Okay, then the category B, no previous sedations done. You will do the workup, the training, and congratulations for winning that lotto. It takes me the better part of 2 or 3 visits at a dental practice to train, to request people going to do their airway training, to get the practice to understand the basic principles of sedation. The facilities, do the premise appear to be well maintained? Sounds like not important, but if they are careless about the way that they behave themselves, they are going to be careless about their patients. Are the recovery and waiting areas separate? And this is very practical. You've got to do 4 little kids for dental sedations. The one that's coming out was perfect. Everything was fine. He wakes up, he's crying a little bit, and every one of the other kids starts screaming and crying, and it's a total mess. Is there good lighting and ventilation in the clinical areas? Is there access for emergency services to the building? One of the places where I refused to go and work was where you had to literally go out the back door, down about 16 steps around the back, and all the way to the front to get to the parking area, and then you've got to duck past the parking area to get to a place where a patient can be loaded into an ambulance. And if you ever have a problem, that's not going to work. It's really going to be a problem. Do you have a wheelchair available? Is there space? Now, at lunchtime, I spoke to one of the colleagues here, and he says this is one of the things that would make it very difficult for him to go and work. If you can maybe get away doing one case, but if you've got to do a few cases at the same spot and you don't have enough space to pack out your stuff and do it properly, you are going to run into trouble. And recovery, difficult enough, but resus. Try to resus when everything is on top of everything. Does the practice layout provide privacy? Can the dental chair be placed in head down? Now, this is another one that I've seen and read and never actually went. And since I prepared for the lecture, I went and checked in as I'm working through the practices. And I think less than half of them can actually tilt down to the point where the head is down. The sedation practice. Are patients normally assessed for suitability for sedation at the preceding appointment? What you do is the night before, you give the call and you've given the patients the paperwork. but it's incredibly much less stress on you if whatever person is going to do the procedure, the dentist, the aesthetic doctor, the whatever, if they've, at their time of seeing the patients, have done the basic questions. So I give the dentist a little piece of paper which he can just tick off, and that helps a lot. Can our patients ask questions? Are blood pressure and pulse oximetry assessed as part of the patient assessment and documented? For the bigger cases, I insist on that. Smaller cases and the kids, you can do your own examination before the time. I think if you do a proper examination, that is not critical. Where are the patients normally recovered? Are patients given a cell phone number to call in case of problems? Do all sedation patients have an escort? Is there an agreed protocol with the local hospital and paramedics in case of an emergency? And this is an interesting thing. With the dentist, it's usually not an issue. But if you have a practice where you are doing work that's in competition to the private hospital theatre complex that's 3 blocks away, and now you want to have a protocol that if you have a problem, you're going to bring the patient there might be resistance. So you literally have to use your diplomacy and get it done and make sure that it's in place. Equipment. Is the equipment for the measurement of blood pressure? Straightforward. Does the pulse oximeter have audible alarms? That helps. Is emergency oxygen available and full? How many times have you been at a practice and all the oxygen cylinders are empty? It's only your 2 little cylinders that's got oxygen in. I went and did a course in adiabatic cylinder filling, just so that I can fill other people's cylinders that's always empty. Is there an ambu bag? Is suction available and working order? And how often is suction cleaned and checked? Is there an AED available? Drugs. How many of you have ever checked if the dentist that you are working with have got emergency drugs in his cupboard? Hands up. Thanks. No, I'm not talking about the drugs that you carry. How many of the dentists, they work with drugs that can cause anaphylaxis and they don't have emergency drugs? They don't have an oxygen bottle that's full and they don't have emergency drugs. So this is the little list I give them. Sorry if they have to throw it away every end of the year. Adrenaline, atropine, cortisone, promethazine, aspirin, salbutamol, and ephedrine. Are all drugs, sedation, and emergency up to date? Staff, and this I have started doing of lately, the names and qualifications of the dentist, the nursing staff, and the assistants, if other doctors are involved in the sedation practice that you are going to do the sedation at. Do they all have currently valid airway certification? Can all staff demonstrate in-house training in sedation or post-sedation recovery? You're going to do that training. There's nobody else that's going to do that unless they write in for the course with Prof. So whatever the poor people in that practice know about sedation is what you train them for. So it's something that I'm not always giving all the attention I probably should. But we really need to have them because the day that you've got trouble, those are the people that's going to keep you out of jail. Preparation for your first patient. Well, that's the new petrol price. So if you prepare for your sedation, you need to ask yourself a few questions. Is it dental? Is it adult or child? Endoscopy, G or C scope? I just want to make a comment on one of the previous speakers. The only time I've ever had a serious aspiration in my hands in anesthetic and sedation practice was a G-scope on a patient that was starved for more than 12 hours. Okay. and he had serious whiteout in his lungs. Recovered, but yeah. Bronchoscopy, ERCP. The reason why I mentioned the type of procedure is that every single procedure has got a treatment plan that you've got to have in your head ready before the time with the equipment suitable for that procedure. MaxFax, trauma, plastic surgery, liposuction, threads, breasts, eye surgery, cath lab, neurosurgical procedures. We do sedation for all of these. And there's some doctors in the academic hospitals that literally are faced with the full gamut of all of this. In private practice, you have a bit of a choice. You can say, listen, I'm not going to do eye surgery, or I am going to do eye surgery, or I'm going to do the cath lab, or I'm not going to do the cath lab. But the point is, if you are going to do it, have you actually sat down and thought about the equipment that you need, the type of patient, the planning of what and where and how? Very important, because you often are under pressure for time. Okay, place. Are we going to do it in a hospital theatre? In hospital, but out of theatre? Out of hospital in a fully equipped procedure room, in private practice, non-equipped room, for example, the dentistry chair. Every single situation, there's more and more reliance on what you have with you, your training and your equipment. So the more away from theatre, the better you have to be trained, the more equipment you have to have, the more you've got to make sure that the people working with you are fully trained. So the greatest risk is not in theatre. Basic training and equipment, training, and training. Literally, if you want to do safe sedation, that's what you go for. You've got your carry bag with all your equipment, but if you're going to do MRI scans, you need the long lines, the specialized equipment, Vaser liposuction, the anti-DVT stuff, the warming blankets, CT-guided brachy, visual and auditory equipment. We've discussed that today quite a bit already, because you monitor the patient from another room. Eye surgery, the specialized local anesthetics, the training to do that properly. Burns cases, the ones that I've had problems was the ones that I didn't do the temperature very carefully. Blood pressure, all of that is so logic, but the one that catches me out is the temperature. So, thank you. I've done it quite quick and short, because I actually want you to share with us the specifics of where you think that a young, now qualified sedationist is going to step into trouble if he hasn't had, or didn't think, or haven't had the training, or doesn't have the equipment. For instance, a very experienced sedationist does not need the capnograph as much as the one that might have the benefit of that capnograph to a greater extent. So I'd rather go to a very experienced, careful sedationist without capnography for myself than I'd go to a young guy with all the equipment and he doesn't look after you carefully. So in that respect, I agree. But on the other side, if you have all the experience and you have the niceties with you, it makes it just so much easier. So let's start off with any questions.
I just have to ask, I think in a practice setup, doesn't matter what work you do, you need to speak to the surgeon about responsibility. Like for instance, last week I worked with a guy and he did extractions. He just left. The child kept on bleeding. The assistant left. I sat there, I couldn't find the plugs which I had to put in the bleeding site. So where does his responsibility stop? Where does my responsibility stop? Do I need to take the patient to recovery? Do I need to recover the patient in full? Does he need to discharge the patient? Who discharges the patient? I think there's a very grey area there, and you need to discuss it with your surgeon, who's going to look after what.
That's critical. And you know that it works the other way around as well. You've done a 3-hour Vaser case, and they were supposed to take 1 hour, and now you're late for the next list. And are you now going to leave this patient who's responsive but still wobbly? Are you going to leave this patient in the hands of the person that did the procedure and go on with your other list, or are you going to stay there with that patient till he's safely out of the door? And it's a question of, even if you think it's okay for, they're not trained and they don't have the experience. So sometimes you just have to take the responsibility and don't be pushed.
Vickers, thank you for this chat, and it's more of a comment than anything else. I mean, us as traveling sedationists inevitably will land up in a new practice somewhere along the line, and it's daunting. And as much as I cringe when I get to a practice that's never done a sedation and you're there for the first time, I think the onus is on the experienced sedationist to train that practice in the proper principles of safe sedation. So I'd rather have any one of us here that are well versed in sedation outside the operating room training a new practice than having that practice under the wing of someone new as well. It's just a comment.
I've been asked to go and do sedations at a new practice in another town. Now, it's already driving a lot more and whatever. I spent about 3 consultations with the practice, all 4 the dentists and their assistants over their lunchtimes. Sorry, that was their time, but it took me 3 full consultations with this lot for them to begin to understand that a sedation needs a certain amount of preparation, that they need to have a certain understanding of airway, that they cannot expect me to do a sedation in room 1 and within 5 minutes start doing a sedation in room 2 and another 5 minutes starts doing it. You know, it just doesn't work. So, and when they eventually understood it, that practice became a star practice, because what they did is they then realized what is going on, and they dedicated a specific sedation procedure room. And then the flow of the patient started working well. And then the moment that you train them and they feel more confident, the assistant is actually more accurate on that capnograph than what you are. She sees, oh, it's gone. And you are still looking to draw up something, and she says, doctor, he's not breathing. If you make them part of your team, it really works well. But I can tell you, if 6 experienced sedationists have worked at a practice and they've all walk out.
I think one of the things that's most can be a problem for young guy is surgeons or personalities, especially with painful procedures, wisdom tooth would have to inject, or multiple injections with full clearance, or bone marrow biopsies where they still have the mindset the patient is under anesthetic, and if the patient moves, they come down on this guy, your patient is moving, and they pretty much feel obliged to make them deeper and deeper, and they must never fall for that. They must never go out their comfort zone because of the surgeon.
Surgeons prefer deep sedations, and sedationists prefer light sedations. And somewhere we've got to meet. It's literally true. And that's part of an ongoing conversation. I have dentists now that says the patient is sleeping too deep, doctor. But that took about 6 years. He's not moving. He's not listening when I'm talking to him. And that is where you want them. They have to understand the principles. So a good team is brilliant.
Thank you, Vickers. Maybe just a comment. Hopefully you've picked up on this lecture that sedation, procedural sedation, is an evolution of your practice, but also a continuum of an admin process. And probably the first thing the vital important thing is when that booking is made, that your receptionist knows what's going on, what's needed, what time, where you need to travel to, how long is it going to take you to the next case, and so forth, and that she doesn't overbook you. Prepare margins. And then also, pre-op, make sure that a patient get your phone call, but also a phone call from your practice with all the paperwork, and that it's been done well in advance, and not that you get caught with your pants down. Just a case last week, a dental practice that I was booked for, got to the practice and the dentist wasn't there, and it was a locum that is looking for a new job, and she might join the practice, but never done sedation before. I just assumed it will be the old dentist. So that also took me by surprise. Again, we will always be challenged with situations, but this is what makes us the experts. So on the one hand, I want to challenge you, don't go out of your comfort zone. On the other hand, this is the way you get to become the expert. You need the experience. And if you don't know anything, or if you're not 100% sure, put a question on our WhatsApp group, phone a friend, make sure that you know people that know and that can advise you. All right, or come and assist you and help you, at least just for the first time. So this is a plea that we want to give you. That's why SOSPOSA is there, to help you to become a better sedation practitioner. All right, our last speaker for the afternoon is Dr. De Wet, my handsome young friend with a big purse. Right. Thank you, Reinhard.
Thank you, Louis. Ladies and gentlemen, before you start, may I just ask, sorry, by a show of hands, who are SOSPOSA members? Lovely, lovely. May I ask, when we're done with this ERCP talk, it'll only be 15 minutes, if you could just stay behind so we can have a special interim AGM. There's just 2 items I would quickly like to discuss with you and get your input on, please. Thank you. ERCPs, who's ever done an ERCP? Okay. You do everything. Lovely. Okay. The whole issue about ERCPs nowadays, nowadays is that the question comes up: no sedation, very light sedation, moderate sedation, deep sedation doesn't really come up, and general anesthesia now and then. So the whole issue is about no sedation, minimal or moderate sedation. Now, ERCP stands for endoscopic retrograde cholangiopancreatography. It's a hell of a long name, but it's basically they do a gastroscopy and they go hunt down bile stones or take biopsies in the common bile duct. In all practical terms, as I've said, they only do to biopsy lesions or to remove common bile duct stones causing obstructive jaundice. Now, we all know that kind of patient. That's the uncle lying in the ward for a week, and it takes a week for the surgeons to make a diagnosis that this guy is jaundiced and he's got a common bile duct stone. Now, they all, know what they look like. So in practical terms, when you do an ERCP, it is like a gastroscopy, but they do a so-called push-through gastroscopy. They go through the pylorus, and then they park the scope just next to the ampulla vata, and then they take a metal tongue and they intubate the ampulla, and they try to either grasp and take it out or to crunch the gallstone. So from a sedation point of view, we have a prone patient. They turn the patient, they normally put the scope in, and then you help them and you're semi-prone. The patient actually more than semi, it's almost 45 degrees up from totally prone. You're shading the airway with the endoscopist. Then there's the GIT scope, or the stack as they call it. And there's the X-ray C-arm, because the metal tongue needs to show up on the X-rays to show them where they are. There's an endoscopist, normally an assistant to him. There's a radiographer. You're all wearing lead aprons, and then on top of everything, they turn the ambient lighting down. So now you're there with a patient prone, you're sharing the airway, you can't really get to the patient's airway, and they switch the lights off. So it can be very, very challenging. I will show you later, the majority of these patients are normally ASA3. There's a study by Charles Katay where they've published that about 60% of all their patients are ASA3 or higher. And these patients all have a list of comorbidities, and they're on a list of chronic medication influencing your sedation that you actually have to take into consideration when you decide on your specific sedation technique. Now, let me put the question to you. How would you like to do the sedation? What do you normally do?
The way we do it,
yeah.
In the X-ray department, the patient's already prone, and my surgeon will do the gastroscopy in the prone position on the left-hand side.
Yes.
And we have a relationship, he knows, and he will tell me when I'm going to expect a painful stimulus.
Yes.
So I use propofol and remifentanil. Okay. And I use small doses of ketamine.
Sorry, what dose of remifentanil would you use?
I start off at 1 microgram. I start the propofol first.
Okay. Yes.
You know, you said I do everything, but at the end of the day, it's the principles remain the same. It's just the position of the patient and what to look out for and the classification of the patient. Yes. So I start the propofol between 1 and 1.5 TCI.
Yes.
Patient's nice and sedated, I then start the remifentanil. But with the capnogram nasal prongs, I'm watching. Once the surgeon has introduced the scope and is about to cannulate the ampulla obvata, it's going to be a painful thing. I give a 20 milligram dose of ketamine. And it goes very smoothly. And then as I know it's going to come to the end, I stop the remifentanil and taper off the propofol. And when it's finished, the patient basically awake and says, is it all done?
Yes.
So it goes very well. So there's only 3 drugs. I tend to shy away from the use of midazolam.
Yeah.
Because if it does make them confused, it becomes a really, a situation that you can't tolerate. So all my sedation basically, it's the same. The principles remain the same. Whether I'm doing that neck surgery or ERCPs,
yes.
And the patient is breathing spontaneously. Yes. As you said, remifentanil is a great drug, but beware of the respiratory depression.
Of course.
And I never go above 1 microgram per kilopower. And I taper it down to 0.3 at the end.
Sounds like a very sensible way of doing it. Right. Let's continue. As I've said, you've got those choices: awake, the different sedations, and then general anesthesia. In the literature, there's a lot of talk about midazolam and meperidine. Now, this is actually the only place where I can think of where pethidine might be of use in sedation, because normally it's a longer procedure, provided that you give it early enough, because it's got a 15-20 minutes onset of action. But that is definitely not, not the first choice. Everywhere it says that a propofol infusion is actually the best way of sedating these patients, because it's got great pharmacokinetics. The whole issue about non-anesthetic personnel administering propofol comes up in the States and Canada. They've approved that now. There is concern about the very fluid continuum and the excellent recovery profile that propofol has. There are some objections to propofol, though, and that is that it has the potential for rapid change of sedation depth. As we've said, the other concern is that there is no specific antagonist. It's always nice when you administer midazolam and you get into problems, you just reverse it. You don't have that luxury with Propofen. Propofen also has marked the synergy with other drugs. You have to keep that in mind as well. And ideally, you should have specialized personnel around for these patients. How do you propose we monitor these patients? In the dark, on their tummies, don't look there. That is my opinion. In the office. This is really the graveyard shift day. Brilliant. Now, you are using an advanced sedation technique, so you have to have a dedicated sedation practitioner there. Basic clinical monitoring, although basic clinical monitoring gets difficult when it's dark in there. ECG, non-invasive, saturation, capnograph, and then some oxygen. There was a publication long ago that where no oxygen had been administered to these patients, they had much lower oxygen saturations as previously.
And why do you say monitoring is difficult? Because the monitors...
Basic clinical monitoring, because it's dark. Yeah, you can see, yes. Yeah.
And you can determine the intensity?
You can, sometimes.
You can also put a setting on an ECG that picks up your respiratory rate.
Yes.
So you can add that into your monitoring, so you'll get a rate from your ECG as well as your capnograph, and you can check correlation, and you can also check air obstruction.
You're right, yes, yes. The other thing to keep in mind is when they started doing this, the guys took an hour and a half, 2 hours to do this. Nowadays, ERCP takes 25 minutes, half an hour. It's a much quicker and a much more slick procedure nowadays than what it used to be.
It's dependent on the expertise of the surgeon.
Of course, yeah, of course. Right. About the safety of ERCP under sedation, the important risk factors, the ASA status, the hydration state of those patients being in bed for a week, the monitoring during that, complications very often encountered were hypoxia, hypotension, and then the possibility of aspiration. There was what I want to allude to is that more than 70% of the patients in that Williams study had an ASA 3 or more. So these are normally sick patients. Cotating published 800 cases. 12.8% of them went hypoxic, 0.8 hypotensive, 0.6% they had to terminate prematurely, and more than 60% was of ASA 3 and higher. And airway maneuvers were needed in 14.4%. So this is not your very nice, easygoing list in the afternoon. All of these patients are sick. All of them demand special care. How do I do it? I differ from Muhammad. I give them normally 1 milligram. That is my standard dose of midazolam. Some ketamine and a propofol titration, like you would do. And the monitoring is as per the slide there. Simon.
Just an interesting comment about, I know we're all sick of it, COVID and things, but what our general experience in our hospital at Critical was that a lot of the procedures that we got standard GA, if there was one, suddenly got, we suddenly got asked to do a lot more sedations for them because people didn't want to instrument airways, and we have an extremely cramped
ERCP area. It's very, very cozy inside there. And usually they got, most people that go up there are fairly new registrars that get sent away from theatre, sort of, the most bizarre thing in the world, to send the most inexperienced people away. But they would do a GA, and then we started doing some sedations for those cases during COVID, and even in the neuro theatre and the interventional theatre. So it's just a comment that also perhaps other things influence what happens in these scenarios, And we gleaned quite a lot of experience, I think, at large to the anesthetic department of the exposure to sedation, what can be done actually.
Yeah.
So sorry for that, but.
This is something that some of you have heard me say before. It's one of the lectures at SASA, I mentioned this. But in one of the major teaching hospitals in South Africa, one of the biggest ones, the endoscopy theatre, as Simon says, is manned by inexperienced people. And the death rate in that endoscopy suite
I remember that.
is 11 per 2,000. Now, they do horrific cases, I can understand that. They do cases like what you've described now, ASA 3s and 4s. But the point is that the most dangerous place anywhere near sedation in the world, exactly as Prof said, is the endoscopy suite.
Yeah.
And ERCP tops it all.
Oh, yeah, for sure. Yeah, for sure. Thank you, Vikas. Prof, there's the microphone.
I think I was lucky. Nadia is here, and when we went to Bloemfontein last month to do 3 days of sedation, I volunteered to do the ERCPs. And it was 6 cases. And I thought to myself, how am I going to do these cases? Because, this is some of the most difficult things to do is ERCP sedation. If you talk about moderate sedation, then I say I wonder. I don't disagree. If you talk about deep sedation, then it seems to me this is the sort of way that we have to follow with a lot of problems that you can face. In any case, Nadia came and said to me, well, all 6 cases were cancelled. And so I said, thank you, Nadia. And Nadia said, what are we going to do now? And I said, okay, get all those people to me and I'll talk about ERCPs, how to do ERCPs. Now, I'm not going to talk what I'm going to say. I'm going to be short. And I said, okay, well, people sitting around, all students sitting on tables and things. It was quite nice, And first question I asked them, I say, okay, we're going to discuss this, ERCP. And the first question I want to know from you is how many of you are doing it? How many are doing ERCP sedation? So I'd be very interested to know how many are doing it. And there was an anesthetist like, well, that man from East London, he put up his hand like that and said, okay, you are doing ERCPs. And I said to him, if you haven't got propofol, what are you going to use? And nobody could answer that question. If you haven't got propofol, can I ask them?
Yeah,
you want to do
please.
ERCP, what are you going to use? What?
Surgeons use fentanyl, Dormicum, that's what gets used in the GIP clinic at Chris Stewart. Actually, we have no involvement there at all, besides for the times that they've given a full amp of Medaz and fentanyl, and then the patient's got either irritable or SATs or 50, and then we get called for the next time because it was a difficult colonoscopy. But the strange thing is we do outreach sedation up the coast, Northern Cape, for Prof. Goldberg
Yeah. Yeah.
Well, there's a very interesting article on this. I've done quite a lot of ERCPs, but I've never used etomidate. And there is an excellent study on the comparison of etomidate and propofol for ERCPs. But they do it a different way. They start off with 1 microgram per kilogram of dexmedetomidine. Inject that slowly, which makes sense for me because that's in hospital. We can use it. And then they give 2 milligrams of midazolam. I'm not a big fan of midazolam, but in any case, they use it. And then they give, okay, to the one group propofol and to the other group etomidate. And they couldn't find any difference in, well, negativity, side effects. They found etomidate, in actual fact, just as good as, well, propofol.
Yeah.
Now, I cannot tell you why. I can just think that the dexmedetomidine made a significant difference because it sounds to me like what Graeme said this morning. This is the same drug. And so if you are doing ERCPs, don't forget about the 1 microgram per kilogram of dexmedetomidine. Okay, what they also added is an opiate, and it seems to me a popular one is to use small titrated doses of fentanyl. I'm talking now about that study. But as said, I have not used the etomidate, but it seems to me that's an option that one could maybe think about. Thanks.
Furthermore, in the Southern Cape, I'm from Knysna, there's a surgeon, Jan Hendrik Barnard, in Mossel Bay, Bayview Hospital. He does the majority of all the ERCPs in the Southern Cape. Everybody gets sent to him. And I spoke to him about 2 weeks ago. He said, Reinhard, I actually do less and less and less for them. He says, I give them a squirt of lignocaine in the back of their throats and a milligram of dormicum, and the patients are happy. He says the pain from an ERCP is actually very, very, very little. So he says quite often he does them wide awake. So that is the difference in opinion that you get.
Yeah, it's quite interesting that you say there is a little bit of pain because there's a study just out now on how many patients complain about pain after ERCP anesthesia. And that's a difficult thing here. How many patients are complaining about pain after ERCP anesthesia? And it's quite interesting, and I think they've been doing deep sedation. So how deep is deep sedation? Well, you can think for yourself. That 30% of all patients still complain about pain, that they were aware of pain, 30% aware of pain during ERCP. So, I mean, this is just a report by somebody, but I think it's reasonable to take note of that. And I think for me, it says that dexmedetomidine is a great alternative or add to our technique that we are using. Thanks, Reinhard.
Thank you. Any other questions? Gesels jy of is jou hand in die lug? Okay. Ladies and gentlemen, thank you very much. Right, the non-SOSPOSA members are free to go. We see you, Louis, what time tomorrow morning?
8:30. Can I just quickly, where's my list that you need to sign? Who's got it? All right. And everybody signed it? Okay. We're going to start tomorrow morning sharp at 8:30. So I want you to be at 8:15 at the latest. And then, There's no something else that I... Right. And if there's any questions or any people that's got any concerns for tomorrow or today, please give us the feedback. We need this to get better. Thank you.
Peter, won't you hand everybody leaving now, hand them a SOSPOSA application form?